So, Jenifer, welcome. And can I pass over to you, please? Thank you very much.
Brilliant. Thank you. Thank you for asking me to speak today. So I'll just open up my slides. Brilliant. Can you all see everything now?
Fabulous. Thanks, Jenifer.
Brilliant. So I'm Jenifer. I'm one of the Parkinson's nurses at Lancashire Teaching Hospitals. We cover a team of 5 nurses, so I'll just tell you briefly about the service that we provide, and then later on in the slides I do mention the other teams that cover the whole of Lancashire, because there's a few different teams. So we're based at Royal Preston Hospital. We cover Preston, Chorley and Blackburn with Darwin. We do cover the whole of Lancashire for certain treatments, which I'll mention further on in the slides. We're a team of 5 nurses, and we do various different clinics, home visits, telephone clinics as well. So I'm going to give you a bit of a whistle-stop tour of Parkinson's and some of the things that can help when you're caring for people with Parkinson's in the community. So there's around 153,000 people in the country with Parkinson's. 2 years ago, it was 147. So we are seeing quite a rapid increase in people being diagnosed. It is the fastest growing neurological condition in the UK. And to be honest, I think it's second worldwide to Alzheimer's. So each day, 1 in 37 people are diagnosed with Parkinson's. So it is on the rise. The next slide is a video. I hope I remember to click the button actually for the sound. I should have done. If you can't hear the sound, well, somebody tell me. But it's a video that is based for hospital staff. That was made by Parkinson's UK, the charity, but I do think it's relevant for everybody that's caring for somebody with Parkinson's. So I'll just pop it on and let's see if it'll play.
Painful as hell. I couldn't cope with this without medication.
Staff just didn't understand.
Couldn't move.
I just kept waiting and waiting.
I'm still not
situation left me.
I was
overwhelmed.
overwhelmed.
No one feel
I
like
still
deteriorating.
long
It makes me terrified of going back to that hospital.
Okay. Did the sound work?
It did. Thanks, Jenifer.
Oh, good. It didn't work on my end, you see. So just a little bit about what is Parkinson's. So Parkinson's is a neurodegenerative condition, and it's caused by, so in the centre of your brain, you've got this area that produces dopamine. And when you are diagnosed with Parkinson's, you've got a reduction in your area that produces dopamine. It stopped producing as much. Dopamine is a neurotransmitter, so that is responsible for us being able to move, being able to talk properly, being able to function. When somebody is diagnosed with Parkinson's, they've already lost up to 80% of those dopamine cells, which is a huge amount. We don't know what causes Parkinson's. There's lots of different theories. In America, they're very keen on, feeling that it's to do with pesticides and things that are in the water over there. In this country, we do consider environmental factors, and there can be genetic causes for Parkinson's, but this tends to be in people that are diagnosed when they're very young, so not over 50, over 55. So Parkinson's, quite often we get asked but I didn't have a scan or I didn't have any blood tests. How does the clinician know that that I've got Parkinson's? And it is very much, a diagnosis is very much on clinical assessment. So when somebody goes to see one of the consultants, that assessment starts from the minute that consultant is called from the waiting room. The consultant's looking for certain markers, so shuffling, whether there's an arm swing, you know, how the facial features are, and that is how we diagnose Parkinson's. There is a scan that can be done. So if the consultant is thinking that there could be a differential diagnosis, then quite often they will do a scan called a DAT scan, or they'll do an MRI scan. But on a whole, the majority of people are diagnosed by just clinical assessments. When they do the assessments, they're looking for that stiffness. So, you know, if you can, the muscles can become stiff in Parkinson's. People have that slowness when they're walking, and some people will have tremor. Not everybody will have a tremor. So I've just got this off Parkinson's UK, just because it's quite a good thing to look at for the 10 early symptoms of Parkinson's. So we all know the usual things that people tend to know about with Parkinson's, so the tremors, the muscle stiffness, the slowness in movement. But some people, when they are diagnosed, they look back like years and years ago, and they may have had certain indicators that may have led to that diagnosis of Parkinson's. So problems with sleep. I mean, a lot of people have problems with sleep, so it doesn't, you know, necessarily mean that you're going to have Parkinson's, but, you know, other things like losing your sense of smell, handwriting being smaller. We've got problems with bladder or bowels. A lot of people have had constipation for many, many years, but absolutely no signs of Parkinson's, but then in later life have developed a rigidity or a slowness in movements. Depression, this can happen, you know, months before noticing any other symptoms of Parkinson's, because we know that dopamine is one of the happy hormones. And depression can be linked very closely with Parkinson's, and so can anxiety. And people sometimes will have a sudden feeling of being so tired, but there's no causes for that when they've had bloods done or anything. And then as time goes on, these other symptoms will develop. So like I mentioned before about what causes Parkinson's and who's at risk, we don't know what causes Parkinson's. We know that it could be a genetic cause, and when we look at people that are under 50, we will often do genetic bloods, just to see if there is any genetic causes. We are an ageing population. We're living a lot longer, so there has been this increase in diagnosis, because, you know, we are seeing people, you know, in their 80s, 90s that are being newly diagnosed with Parkinson's now.
No, it's me. I hadn't clocked on it.
It is really important to note that it isn't just an older person's condition. There are people out in the community, across the country, that are of working age. There's one gentleman that's very well known in the Parkinson's community who was diagnosed at 8. That is a very rare case, but he has lived with Parkinson's for 50 years. So we do know that it isn't just for an older person. And recently they are now looking at whether there's whether Parkinson's is caused in the gut. So we've historically thought that it could, you know, that it is a disease of the brain, but they're wondering whether there's proteins that are in the gut. So we're really looking into research about gut health and having good gut health to try and prevent Parkinson's. But obviously that's only just going through the research stages. So when we talk about Parkinson's, everybody knows about the motor symptoms. You know, people say, oh, it's somebody that's got a bit of a shuffle, or they might have a tremor. they might stop when they're walking through doors, and that's what we class as motor symptoms. So this rigidity, that stiffness in arms and in legs, that slowness in movements, that I'm sure a lot of you have cared for people with Parkinson's, and people can stand up from the chair and they really struggle to get started walking, and it's called festination of gait. Going through doors, like I said, and people can freeze and get stuck, and using techniques to help with that. And then obviously people are more at risk of falls, and a lot of people have dizziness on standing, which is a huge thing, which then can cause falls as well. And then people do have muscle cramps and can develop dystonias, which is like a fixed cramp, or people find that the hand goes in a certain position and then it'll relax, and quite often we have to refer for people to have Botox to help with that. So them are the motor symptoms that we think about, and on a whole, a lot of people do know about them. But then when we look at Parkinson's, we look at the non-motor symptoms as well. So there can be up to 40 non-motor symptoms. So people can have incontinence of urine and bowel incontinence, constipation, a feeling of being very tired, depression, anxiety. A lot of people feel that they have an increase in perspiration. They really feel the temperature, so it might be a really hot day outside, but they might still be in the house with the heating on full because they feel cold. Or the other side of it, that they can feel exceptionally hot all the time, whether it's -2 degrees outside, they will still they'll feel absolutely boiling. Sleep problems are a huge issue for people with Parkinson's. People often report that they can get off to sleep, but then they're waking every hour, they can't settle. People might have vivid dreams or acting out of dreams, so they're hitting, kicking, shouting out overnight. Swallowing problems, so we work very closely with the speech and language therapists, and we try and get access to them as soon as possible, just to try and help with strategies to help with swallowing problems. Speech can go very quiet and be quite mumbly at times. There are specific speech therapies that we can refer to, called Silverman voice therapy, which is designed for people with Parkinson's to help voice projection. And there's like trigger words, but it's quite an intensive course of attending the hospital over a 2-week period. But we try and get people onto that course as soon as possible to help. Eye problems, so double vision, dry eyes. I've had people recently that have had very weepy eyes, and it's turned out that they've got very dry eyes. So we're always need to be aware, you know, if people are complaining of changes in the vision, to get them checked out. Pain, as you can imagine, if you're feeling stiff and all your muscles are tense and you're unable to move, the pain, you know, you can imagine in your neck and in your shoulders could be quite a lot. So we need to consider pain management. Dementia, not every person that has Parkinson's develops dementia, but there is that link, and quite a few people do go on to develop Parkinson's dementia as the disease progresses and they reach the advanced stages of Parkinson's. Hallucinations, so with our medications we have to finely balance things, and the more that we increase medications, there is the risk that we could cause hallucinations. But also with the link to dementia as well, sometimes hallucinations can be a first sign of people going on to develop dementia or mild memory problems. So it is something that we have to keep an eye out on. But it's definitely multifactorial Parkinson's. It isn't just somebody with a tremor or a slowness in movement. So the next slide, I've put this in just because when people talk about Parkinson's, this is the picture that's on Google, basically. And this is how they picture somebody with Parkinson's. So an elderly man shuffling, bent over a little bit with his posture. But people are trying to move away from this picture in the Parkinson's community. And there's a gentleman who is young, works for Parkinson's UK, but also works in the emergency department in a trust elsewhere in the country. And he developed Parkinson's young, and he doesn't look like this man in the picture. So what he's designed is this picture of, it isn't just somebody that's got that shuffling of gait. So if we go back to the other picture, it literally just points out rigidity, tremor, short shuffling steps, stoop posture, reduced facial expressions, where really, as we've just listed all the non-motor symptoms and the motor symptoms, we know that there is a lot more to Parkinson's than just the physical things that people see. So he's made this picture, and they are trying to use this more than use the other picture. So how do we treat Parkinson's? Well, we can't change the disease trajectory. It is going to deteriorate. We do not have any medications that can halt the deterioration of Parkinson's. We very much use medications to improve quality of life and to help maintain symptoms. Oral medications are the main treatment. We've got levodopa, so I'm sure many of you have heard of carbidopa and carbidopa. And they are used by restoring the dopamine levels in the brain. That medication is the gold standard medication for Parkinson's, but it has been around for a very long time. And obviously we want more treatments to be available for our patients, but those levodopa-based medications are the best ones at this time. We've also got medications called dopamine agonists. The levodopa preparation and the dopamine agonists tend to be the main oral medications that we choose to use on people. There are lots of other medications as well that we can use to help boost the Sinemet and the Madapar, but these tend to be the medications of choice. So things to consider when you're looking after people with Parkinson's is that, so if people are diagnosed younger, after several years of being on your levodopa treatments or your dopamine agonist treatments, you can start to run into some problems, so like motor fluctuations. We tailor medications to each individual's needs. So I could literally see everybody in this whole world and I wouldn't meet two people the same with Parkinson's. It's very person specific. And when we set timings for the medications, we do this to try and help with the motor fluctuations. And then if people do start to notice that the medications aren't lasting as long as they have done previously, then we're able to tweak the timings, add more medications in. And that's why we're so strict with timings. Some people can also develop dyskinesias, which is like a wiggly writhing movement. And that is because the condition has continued to deteriorate, and it may be that the response to the doses that people have been on previously are a little bit too high for them, excuse me. Postural hypotension, this is a huge thing for our service and for people with Parkinson's. So a lot of people experience a drop in the blood pressure when they stand up, so they can feel dizzy and lightheaded. We have people that are fainting, and this can be because there's postural instability in Parkinson's, but also because the medications that we prescribe can cause a drop in blood pressure. So we're always offering safety advice, making sure people are careful when they're standing up, taking the time, not rushing. Are they drinking enough fluids? I think there's another slide that I go in a little bit more detail about postural hypotension, but it is really important. You know, when you see that people are suddenly deteriorating in Parkinson's, we don't expect somebody to suddenly deteriorate. It's a slow progressing condition. So if somebody has suddenly become worse, they're unable to move, or they just suddenly just don't feel as well controlled with the Parkinson's, we're always going to look at any other conditions that they may have. You know, is there any medications that they've been started on that could be affecting the Parkinson's control? Infections. Quite often we get a lot of phone calls because people have suddenly deteriorated or they've suddenly developed hallucinations completely out of the blue, and quite often it's because they've got a urine infection or a chest infection, or they're constipated. So that's something that we will always look into this first. You know, we look at lifestyle as well and preference for patients and what goals that they want. Some people want to keep on as minimal amounts of medications as possible, and they're quite happy just ticking over and you know, staying on a low dose to try and prevent any side effects. I've mentioned hallucinations. We also have got to be really aware of impulsive or compulsive behaviours. All of our medications do have a risk of people developing impulsive behaviours or compulsive, and this means that they may suddenly start gambling, hypersexuality, excessive eating, hobbyism, you know, collecting things. You know, people might have hundreds of tins of soup that they've just felt this compulsion and this impulsive behaviour to just buy lots of soup. So we're very on the ball about it, because we, you know, the last thing we want is people to have gambled thousands of pounds or, you know, become hypersexual. So it is something that we're very, very hot on, and it's, you know, we like to have a very open and honest relationship with our patients. There's nothing that we like to think that they can't, you know, there's nothing that they won't come to us and speak to us about. Sleepiness. So if somebody suddenly starts becoming more sleepy, that can be a result of the treatment. Some people find that they have sudden sleep attacks, so they might be literally sat eating a meal and then the face is in the plate, unfortunately, because they've got this overwhelming somnolence, we call it. So that's something that we keep an eye on. And obviously falls, we refer into the falls team and the frailty team in Preston, just to help support people that are having falls. And it can be really tricky with the fall side of things, because we can try and do the best that we possibly can, but people with Parkinson's can feel unbalanced. I always think of it as the centre of gravity being a little off kilter, so then they're more at risk of falls, and the medications will not always help with that. So things like, you know, keeping active, trying to do certain exercises can be really helpful in preventing falls. So I've just popped this slide in because this is some of the advanced treatments that we do. I know that some of you will be very well aware of apomorphine and the pump and the pen, and then there's Duodopa as well. At Preston, we offer apomorphine and Duodopa. We don't offer deep brain stimulation, but we do refer into other centres, so like Salford and the Walton Centre, for deep brain stimulation, but our consultants can assess for that. We do cover the whole of Lancashire for this treatment, so we can be going up to Lancaster, Clitheroe. So if anybody was to be put on any of these treatments, they would automatically come under our care, as long as they're under the care of a neurologist at Lancashire Teaching Hospitals. There is a new treatment that's coming out as well, just to be aware of. It's all very much in the pipeline with us at the moment, but and the planning stages, but there is a new treatment that's very much like an apomorphine pump, which is the one in the middle, but it's called Pro Duodopa. So the Duodopa that's in the big the big pump with the reservoir at the bottom, it's a new version of that. Duodopa is currently given through a PEG-J tube, but they've developed a new version of Duodopa called Pro Duodopa, which will be a subcutaneous pump. So it'll be like the apomorphine pump in the middle. But like I say, it's very exciting that we've got this treatment that's coming. But we're very much in the planning stages of this. If you ever come across anybody that is on advanced therapies, so apomorphine, Duodopa, always do reach out to the Parkinson's nurses. I've got a list at the end of the slides which lists all the nurses in the area, but always reach out for any advice, or just come directly to us at Preston, because we're always happy to advise and help any way that we can. So nil by mouth, obviously when people are reaching the advanced stages of Parkinson's or palliative, or if they're having a dip because they've got an infection, it can be really difficult to get people to take medications. It might be that the swallows failed and they're unable to take the medications, or they're refusing to take the medications. So we always say seek help. So whether that's calling the Parkinson's nurses or calling the GP, it does have to be addressed immediately to avoid delay. The last thing we want is people to be going days without medications. It can be dangerous, and people can go on to develop a rare condition which can result in death if there's a sudden stop in Parkinson's meds. So we always say please do seek advice straight away if there's any concerns. So medications on time is an absolutely massive topic, and I could probably talk about this for a week if I'm honest. It's something that I'm very passionate about, and we're doing a lot of work about it in the trust at the moment. So they are time critical medications. We set the timings of the medications to specific patient need. We don't do it because we're being awkward. We don't do it because we've just picked random times out to set the timings of the medications. It's very much that somebody may have started on the medications 4 times a day, 4 hourly, but then what they may have noticed is that, say, an hour before the next tablet's due, they start to notice that the Parkinson's symptoms are returning, so they may start to shuffle again. They may feel very anxious. That is a massive symptom that we see a lot of when the medications are wearing off. So they might feel anxious, they might start to choke when they're eating, being able to get up, be able to have a drink, and it's because that tablet has worn off. I always think of medications as or the part in the middle of the brain. So you've got a bottle and it's got a hole in the bottom. So you have a tablet and we top up the bottle, but it's still got a hole in the bottom. So it's always trickling away. And over time that trickling will become faster. So when people are noticing that they've got these fluctuations and they're starting to notice the return of the symptoms, it's because that medication's worn off. So that's when we come in and tailor the medications. So it might be that someone might be on medications every 2 hours, but that is how we help that person to make good quality of life. Parkinson's UK doing a massive drive on medications on time, because it's just as important in the community as it is in the hospital. And I think the video that I showed you at the very beginning really highlights that it is a lifeline, this medication to people. So the medication should always be given within 30 minutes of the prescribed time. If not, then that person could end up, feeling dreadful, like in that video. I have got another video to show you soon, which is a bit of a longer video, but it does really show the difference between having meds late and on time. We use, in the hospital, we set alarms. A lot of the nurses on the ward set alarms on the phones now. We did provide every ward with a clock, an alarm clock, but that was pre-COVID, and I do think they've probably wandered off a little bit now, these clocks, which these things do. We use the blue clock that's pictured there. It's a wall chart. Nothing on it says Parkinson's. So it's, you know, it's maintaining confidentiality, but we use it above the beds to circle the timings. So then it's just a visual prompt for the nurses on the ward. Those are available from Parkinson's UK and they're free. But we have started providing a lot of people with clocks and with wash bags. And there's also stickers that can be attached to it on any paper, records, Mars sheets, just to help as a visual prompt. So if meds are given late, which I've probably already covered, some people are unable to swallow, then they're at risk of aspiration. They're unable to speak or move, and then that increases the dependence on staff. At worst, if they are missed totally and it's, you know, quite a few doses have been missing and days, people can develop Parkinsonism, hyperpyrexia syndrome. So that is when they may have a very high temperature, very, very stiff, and when bloods are taken, they'll find that the CK is high as well. And it can be fatal. That's why we're so obsessed with making sure that meds are never suddenly stopped. And a big thing that somebody said to me, and it's always stuck with me, is when they've been given meds late, they feel a loss of control, and people just can't deal with not being able to do anything, and everything's out of their control, which is it's really sad that a person can feel like that. So the next video that I'm going to show you is a lovely lady. She's not one of our patients, but Parkinson's UK gave me this video, and she describes everything that's happened, but she did forget to take one of her Parkinson's meds. She's a young lady, and it really just shows exactly what can happen. So I'll pop that on now.
Right, I've done something really silly tonight. I went out and I forgot to take my medication with me, so
Jenifer, I think it's paused.
I'm
Oh, was it?
just over
Sorry.
now.
Oh.
What's the time?
9.
Coming up to 2 hours late for taking it. So I thought it'd be quite good to show the difference. Next time you see me, hopefully I won't look like this. I'm just going to try and walk up and down the room. Down. Trying to walk. This is it. It doesn't get any better than this when you're on the medication for 2 hours. And I'm going to make it to the end. It's extremely painful all down my left side, and it feels like lead weights on my feet. Really, really concentrate. So one end I'm going to try and make it back down now. It's really hard. Yeah. Note to self, don't forget my pills again. This is an all day without pills. This is just missing one session of pills by 2 hours. I can't imagine what it would be like if I missed all day. Sit down as well. Oh, that's so painful, my arm. Oh, that's it. Hello. part 2 of a video I done the other night. I went out Sunday night, 2 nights ago, and I hadn't taken my medication with me. By the time I got home, I take my medication 2 hours late. So I wanted to do this video in contrast to the other video, so people can see the difference of and the importance of taking the medication on time. So I'll do the same things I've done the other night. The first thing I've done was just this. Show my hand. We'll shake. And I'll just walk from one end of the living room to the other. The other night I could hardly pick my feet up, on my left side predominantly. Tonight everything's okay, my body works well, and I feel as normal as I'm ever going to feel. And that's it. I just wanted you to see the difference between the 2 days. Thank you.
Okay. So yeah, that's Sharon's story, and I think it really does show quite clearly the difference between having meds late and having meds on time, and what an effect it really does have on people.
Right.
So we talk about idiopathic Parkinson's, but there is another side of Parkinson's, which sometimes people can be diagnosed with Parkinson's, but their condition will rapidly deteriorate. So where with idiopathic Parkinson's, we expect it to be a slow, slowly progressing condition. Sometimes there can be some red flags where people have suddenly started to fall backwards, or they've developed hallucinations very, very soon after diagnosis, so like within the first 2 years. So we call these people are often diagnosed with a Parkinsonism, but they can have progressive supranuclear palsy, CBD, Lewy body dementia, and multisystem atrophy. So, and it is more of a rapid deterioration, and it tends to be between 5 and 7 years. So it is very much life limiting. Whereas Parkinson's, idiopathic Parkinson's, people can, live for 20 years. But it's just to be aware of that, because we still see people with Parkinsonisms and the conditions listed, and we offer support. We'll refer to social services falls team. We signpost to the charities. The MSA Trust have a specialist nurse that we can link into. We're linking with St Catherine's, the hospice, or we'll do advanced care planning with people, and we'll refer to like speech and language therapists, because speech can very rapidly deteriorate. So we look at voice banking for people that have got Parkinsonisms. So it's just to be aware of that. You would still, any person, if you ever needed any advice, you would still come to us. With Parkinsonisms, the medications that we use to treat idiopathic Parkinson's, you may see people that are still on medications if they've got PSP and MSA, but they're not as effective. So we just keep a closer eye on these people and try and support the best way that we can. So I spoke to some of our patients and asked them about what challenges do they face having Parkinson's. And the obvious ones were activities of daily living, washing, dressing, being able to fasten buttons or a zip. It can be really frustrating. Accessing food and drink, being able to just carry a cup of tea from the kitchen. If they've got tremor, it can be really hard work. Or going out for a meal, people quite often say, I'm not going out for a meal because my tremor's so bad, people are going to look at me, I'm going to get food everywhere. Another big one is being heard. They feel that they'll quite often, because it's easier, let others speak for them. This can be because slower thought processes and a quieter voice. But you'll find that people will just often sit back and let relatives speak because it's just easier for them. People have reported to us that they've been accused of being drunk when they've been out and about because they've got these wiggly movements, or they might have those shuffling steps, or I'm sure some of you may have seen people that look like they're running, and people have, you know, shouted at them in the street and of course, you know, accused them of being drunk. And it's just, you know, it really knocks people's confidence. A lot of people walk around with badges on saying I have Parkinson's, be patient. And there's one gentleman who is very dyskinetic, not in our area, he's just very well known in the Parkinson's community, and he does have a t-shirt that says I've got Parkinson's, I'm not drunk, but it doesn't say drunk, just so he can get the message across, because he was, you know, sick of people accusing him of being drunk. So also as well, every day is a challenge. So no hour can be the same, no 2 hours, no 2 days will be the same. It's really important to be aware of the on-off phenomenon. So when somebody's on, they're able to do everything that they're able to do. You know, they might be able to get washed, get dressed, make themselves a cup of tea, but then they might have a spell where they're in the middle and things might be a little bit harder, and they might not be able to, say, carry the cup from the kitchen, but they can still walk and they can still mobilise safely, to being off where they're sat or stood and they're unable to move, and that's when the medications have worn off. And it is that fluctuation that we've got to be aware of. So you know, it's being aware that just because somebody was able to give themselves a drink an hour ago, when you next go, they might not be able to do, and it's because it's a fluctuating condition. This is something that I've just popped in because it is quite important. We find that some proteins can interfere with the effects of the levodopa medication, so carbidopa, carbidopa. We advise all our patients that they should take the medications at least 30 to 45 minutes before meals. What happens if they don't do that? If, say, they have chicken for lunch, and they have the tablet at the same time, when it hits the stomach, it fights basically the chicken and the tablet, and they change into amino acids, so you don't get as much out of the tablet as you would do if you didn't have it with protein at lunchtime. Obviously, we want all our patients to have proteins in the diet, but just trying to avoid it around tablet times. And also we recommend having a good glass of water as well with the tablet, because it helps to activate it. We want people to have, you know, lots of fruit, vegetables, fibre to help with constipation. We know that if somebody is constipated, the tablets can just sit there and not absorb as well, and then you can have an accumulative effect later on in the daytime. I recently went on a study day and there was pictures of somebody's gut, and what they'd done is they'd taken the Parkinson's medications, and then 2 hours later they used a camera, and in the gut, the nice yellow cinnamon, it was called carbidopa, was still sat there unabsorbed. So it really is important to be on top of constipation. I've discussed postural hypotension, so we try and say avoid large meals, you know, small meals, little and often, reduce carbohydrates, sugary foods, and add salt to diet as long as the person's ever been told not to. And same with increased fluid intake, as long as, you know, no fluid restrictions in place or any heart problems. And I've covered all that bit. So then we talk about exercise. We're really keen on exercise, and I know that can be very difficult in certain areas, but we do want people to try and keep as active as possible. So as long as people are safe and the staff available to walk with people, so they are safe and not at risk of falling, we want people to be as mobile as possible. we know that research shows that people that are more active do better with Parkinson's. So our very newly diagnosed patients, we're very keen on saying, you know, you need to be active, you need to keep moving. It's really, really important. One of the gyms, Pure Gym, I think it is offering people with Parkinson's a free membership for 12 months and a carer. So it's a really huge thing. Exercises like Tai Chi and yoga, Pilates, which can be chair based, are very good to help with balance. There's lots and lots of things in Preston. There's dancing, there's boxing, there's snooker, there's table tennis. There's lots of different activities that are available in the community. And then the support that's in the community. So there's local Parkinson's groups, which are an excellent source of support for people. There's one in Chorley and one in Preston, and there is in the other areas as well. So Lancaster and Blackpool have support, and I think there's a cafe in East Lancs. I've mentioned about the exercise classes. We do refer people to Encompass because, you know, we want to support carers as well as the patients. We need to make sure that all our carers are, you know, being looked after as well, and that there's plans in place when people are at home. So, you know, that spouses or, you know, children aren't struggling, and they've got plans in place to access care. We've just started a newly diagnosed session that's running with Parkinson's UK. We've got our next one in a couple of weeks, and we invite people to come so we can try and make people feel empowered with Parkinson's, rather than, you know, being given a diagnosis and off they go, and then they've got no access to anybody until we get the letter. So we're trying to bring people. We have it at St Catherine's, the Mill, and you know, we have people that come and chat, and we've got some exercise sessions that run in that afternoon, just to show that people, you know, one of the young people with Parkinson's that works for Parkinson's UK, he's very much like, I've got Parkinson's but it doesn't have me, and that's his motto. There's also lots of podcasts as well that people may have heard of that are really good, with Jeremy Paxman, and it's called Movers and Shakers, and they've recently gone to the government to ask for support with the Parky Charter, which is looking at access to us and clinicians as soon as possible, which hopefully we should see some change. So how you can help, a lot of people said they just want to be listened to. It can take a while for people with Parkinson's to say what they want to say, but you know, it is important. We ask not to rush people with Parkinson's, which I know, you know, we're all so busy, but it is, you know, if we take our time with people and have a good understanding of the condition. If you need anything, contact the Parkinson's nurses. We're always happy to help and support the best way that we can. And then there's further training. So there's lots and lots and lots of training on Parkinson's UK Excellence Network, and there is a section for health and social care staff. There's so much on there. We've done an e-learning that's in our hospital and is accessible through Parkinson's UK, that is about meds on time and just goes a little bit more in depth about Parkinson's and the things that we can do to help support people. So that's on there, and there's lots and lots and lots of different things that you can access. So I definitely recommend having a look at that. And then this is how to contact us. So like I said, we're based at Lancashire Teaching Hospitals and at Preston, and we currently only see people that are under a neurologist from Lancashire Teaching Hospitals. We are hoping that this is going to change in the near future, so we'll be able to see people that are under care of the elderly, but it is in the planning process at the moment. For the East Lancs nurses, they are community based, and they run from the Northern Alliance. East Lancashire Alliance. They've just moved recently, but they very much like how we work, except they are based in the community, but they do go into Blackburn Hospital, Burnley Hospital, if there are patients in the hospital that need to be seen. And then the Blackpool nurses, they're community based, but they don't go into the hospital. And then the Lancaster nurses work like us as well. They're based in the hospital, but do community as well. I don't know if anyone wants to take a picture of that, and then you've got all the contact details. And then the last one is just any questions, and thank you for letting me speak.
Thank you so much, Jenifer. That was absolutely fabulous. Thank you so much for sharing all your knowledge and expertise, and also those real top tips and you know, personal stories. And Sharon's story was incredibly moving and demonstrated the difference. I don't know if anybody has any questions. If you do have one, and you know how to do it, if you want to raise your hand in the chat, oh, fabulous! There's questions coming in already. Lisa, could I ask you to monitor the chat ones? And there's somebody with their hand raised. Let me just. Oh, that's me raising my hand. Sorry, I can't see who it is. Julie.
Hi, could I just ask, please, is it as important to receive the meds on time in Parkinson's-ism?
Yes. Yeah. Yeah, it's the same. It's the same. We just say the same thing, yeah, for both.
That's great. Thank you.
That's brilliant. Thanks, Jenifer. Thanks, Julie. Lisa?
Okay, so the first one came in from Anya, and it was, could you please explain deep brain stimulator?
I will try my very best, but it's not something that we do. So quite often, if people have uncontrolled symptoms of Parkinson's, so we've tried oral medications, we've tried apomorphine or duodopa, and still really struggling. So mostly we see it quite a lot with people that have got a very, very bad tremor. So the person has to be under 70, but they have it can be a little bit more flexible as long as that person's cognitively intact. And then what they do is they insert probes into certain areas of the brain, and then these wires then lead down to like a pacemaker thing here. But my knowledge isn't brilliant about it. And then it's quite, if you go on YouTube, you can see some quite dramatic videos of when the DBS is off and somebody can have a really bad tremor, and then they switch it on and the tremor can go. So it is an amazing thing. But yeah, we have to refer on to other centres, our movement disorder specialists, which would be amazing if we had it at Preston, but we don't, unfortunately.
Okay, let's have a look. Are there any more questions? Yes, Dawn, I'm just actually, well, Jenifer's been talking, I've been listening and doing a certificate of attendance as we speak. Multi-skilling. It seems that everybody's enjoyed it. Julie from Crystal Hall has said, thanks so much, Jenifer. Could listen to you all day.
Thanks.
And we've also been asked by Thomas as well if it'd be possible for us to email the slides out as well. So I can do that with the certificate of attendance. Is that okay? Brilliant. I'll do that for you all. Even more reason to put your names in the chat if you've not already done so. I'm just having a look. If Malik and Patty are still on the call, if you could just pop your name and workplace down and an email address, then I can get the slides and everything sent out to you. Any guidance for patch as well from Anya?
So with the reticotine patch, the reticotine patch is a treatment in itself, and sometimes people early on in diagnosis will have a patch in place, but we most commonly use it when somebody's nil by mouth or end of life to keep people comfortable. With the patch, we always there is a calculator that you can use through Parkinson's UK called the Optimal Calculator, but we always say just come to us and we'll help with that. The thing is with the patch, it isn't always the right thing to give to people, because their oral medications is the best treatment that they can be on. Obviously, if there's swallowing problems or they're end of life, then we would look at the patch. But it can cause hallucinations, the patch, drowsiness and agitation. So we are very careful with it. It's a good medication, but it isn't. I think sometimes, especially in the hospital, it can be seen as a bit of a quick fix. If somebody can't take the tablets, let's put a patch on somebody and it'll be all right. Where really what we want is people to continue with their oral medications, whether that's with an NG. But obviously, if an NG tube or a PEG tube isn't appropriate, then we would go down the route of the patch.
Fabulous. Has that answered your question?
But any problems, just always go to one of the Parkinson's nurses. We're always happy to help with the patches, because it can be a bit of a minefield, to be honest, with the patch.
Super.
Thank you.
Do we have any more questions? Sorry.
Somebody did say, will there be any more like this, any more webinars? Yes, there will, Kim. Obviously, they'll be advertised. I think the next one we've got booked in the diary, so I can send out the information for that as well for you today. I'll add you all to the invite.
I've got it right here as well. So it's Thursday, the 20th of June from 1 till 2. And that topic is on frailty or aging well. So please do join us for that. Well, with 1 minute to spare,